So I think we have some time for questions.
First question here. Have you had success with multiple medically refractory patients, PRN, daily dosed SSRI, and lidocaine after a PFPT treatment?
Yeah, I mean, I have to point out that when we say refractory, we have to talk about the fact that refractory still is normal for these patients. Refractory and premature ejaculation are kind of, we're trying to work against Mother Nature or God or whoever you believe in to make you last longer when everything about sex is about procreation, largely. And so it is an uphill battle. And so I have had success, but it's the long game. And when we talk about pelvic floor physical therapy for patients who don't get immediate success with delay sprays, don't get immediate success with SSRIs, have severe premature ejaculation, I continue down the same path, right? Because just like going to the gym, if you work out your bicep once a day, twice a day for 3 weeks, for 3 months, you're not going to be the Arnold Schwarzenegger of biceps. It takes a lot of time to train the muscles of your pelvic floor to work in concert to avoid premature ejaculation. The same thing with your bicep happens to your pelvic floor. So even for men who come in to see me who are refractory to everything acutely, I think they're the ones who benefit the most from pelvic floor physical therapy because they have the most to gain.
Certainly. Alrighty. Next question here. How do you clinically distinguish between lifelong premature ejaculation and acquired premature ejaculation? I guess we covered that a little bit tonight, but someone did.
Yeah, I mean, it's via an H&P. I mean, asking these patients how long they can last, they will tell you down to the second. If they have had this issue their whole life, they will know. From the first time, they can often pinpoint my first partner, my first few sexual experiences, it was horrible for them. And they know that it has always been this way. For the patients who have not had lifelong PE, who it's acquired, they can often pinpoint the event that made this happen. And so the main difference for me is I'm more critical of the patients who have acquired PE because I'm more concerned about a cause. And so I'm making sure that I'm, checking their thyroid panel, checking their testosterone panel, asking them about their nerves, asking them about other biological mechanisms, trying to figure out if there's a treatable cause.
Definitely. All right. Next one here. In men recovering from prostate cancer treatment, how common is premature ejaculation compared to erectile dysfunction? And are they mechanistically, I don't think I said that right, but mechanically related?
Yes and no. We don't really understand the incidence of premature ejaculation in the context of prostate cancer. The reason why is because premature ejaculation is oftentimes lumped in the category of ejaculatory dysfunction. And the ejaculatory dysfunction can include painful ejaculation, dry ejaculation, and the incidence these after prostate cancer surgery is much higher. And so teasing out the men with premature ejaculation after prostate cancer has largely not been done yet. Mechanistically, very different. I mean, I think we understand that ED is nerve damage. Why men would develop premature ejaculation after prostate cancer is more related to changes that happen in the anatomy of the pelvic floor. You remove the prostate, you remove the seminal vesicles, you reanastomose the bladder to the urethra. The architecture of the pelvic floor changes and the sensitivity may change. And so although there is some overlap in that prostate cancer changes the pelvic floor, I think ED and premature ejaculation are largely different in the cause and largely different in the treatment.
Certainly. Okay, we got a couple more here related to prostate treatment. So what role do physiological factors such as performance anxiety post-cancer treatment play in premature ejaculation compared to purely physiological causes?
I mean, psychology is always huge in these patients. And so if you're talking about a man who develops premature ejaculation after prostate cancer treatment, a lot of times the commonality is anxiety. And so anxiety about sexual performance is incredibly common after prostate cancer treatment. because these men have difficulty with erections, their sex life is different. They have dry orgasms. They claim their orgasms don't feel the same. And so premature ejaculation often happens as all of those things come together. And what we know is that with 70% of men who have acquired PE also have anxiety, the overlap is the same. It's the serotonin issue. And so it's kind of a vicious cycle because these men develop difficulty with painful ejaculations. They develop difficulty with erectile dysfunction. They're in bed. They're overthinking their performance. They're critical of themselves. They're developing anxiety. And the next thing that happens is premature ejaculation.
All righty. One more prostate question here. So does incontinence and pelvic floor dysfunction contribute to ejaculatory disorders in these prostate cancer survivors?
I mean, I think we talked a little bit about that in the last question. I do think prostatectomy following a prostate cancer diagnosis does change the pelvic floor, which I think is indirectly also linked to incontinence. And so any sort of anatomical changes to the pelvic floor can increase sensation, can cause premature ejaculation. I often think there's an overlap between prostate radiation for prostate cancer and inflammatory conditions like prostatitis. So that inflammation that happens following radiation therapy and the prolonged inflammation that happens from cellular damage can lead to heightened sensation as well. And so anything you're doing to that area that's having an impact on sensation and nerve conduction can lead to issues with premature ejaculation.
All righty, and we have our final question here is a good wrap-up question. So do you foresee gene therapy, neurostimulation, or any other emerging technologies playing a role in the PE management in the next decade?
Yeah, let's hope. I mean, I think we understand that the serotonin and serotonin receptors are largely controlling ejaculation. I mean, dopamine's at play, oxytocin's at play. And so targeting those receptors and targeting those neurotransmitters could potentially work, but they're so broad in what they do that we have to be careful about what we're doing. And so gene therapy targeting those receptors, gene therapy targeting the neural pathways at play definitely is an option. I do think neurostimulation is an interesting concept. In the same way that we do posterior tibial nerve stimulation for overactive bladder, in theory, we could do posterior tibial stimulation for the ejaculatory center. I don't know if it'd be the posterior tibial nerve, but in a way, we could work with the dorsal penile nerve, sacral nerve latency studies, understanding that pathway. There are surgical options for cutting the dorsal penile nerve. I don't do those in my practice. I have had patients who've had it done. And so any sort of neurostimulation at the level of the afferent nerves or at the level of the spinal cord does offer an interesting play. I think what I'm seeing in my practice more commonly, and what I think the future over the next 5 to 10 years, is data-driven solutions for premature ejaculation. So app-based solutions with training, real-time tracking, allowing patients to understand the impact of a delay spray, the impact of pelvic floor physical therapy, seeing progress, seeing that dopamine-induced reward network, reward sort of pathway happen, I think actually leads to better outcomes. So I'm optimistic that as we have data-driven options and solutions for men to track and monitor their premature ejaculation, I think we're going to get better outcomes. And so that's where I see the short-term future. But again, neurostimulation and gene therapy, of course, they are reasonable options in the future. I just don't see them in the next 5 to 10 years.
Thank you for taking the time to answer those questions. We'd like to thank Dr. Brian Steixner for presenting tonight and thanking everyone for joining this MenMD online clinic. We hope you found this discussion valuable and that helps you in your practice.
If you found this video helpful and want to stay in the loop with our growing men's health community, be sure to subscribe to our channel and click the bell to be notified when new content is available.